advance. So epithelial lesions, being very, very important, are lesions that arise from the surface epithelium. So you've all had histology, and you know that the lining of the mouth is mucosa, and the top part of that is the epithelium, and underneath the epithelium we have connective tissues. You started your discussion, probably all but finished a couple little topics of soft tissue lesions, yes, with Dr. Grandi? No?
Yes.
Yes. So those are things that arise from under the surface of connective tissue origin. Today we're looking at epithelial lesions that arise within that surface epithelial layer. There are a variety of different abnormalities that are possible to arise from that surface epithelium. Sometimes the abnormality is because of excess keratin on the surface. We call that hyperkeratosis. If we have pycnotic nuclei, degenerated nuclei that are still visible histologically, we call it parakeratosis. But basically it still just means thickened surface epithelium. Do all of the sites in the oral cavity have epithelium on the epithelium with keratin on the surface? No, not at all. So where do we normally have keratin? Gingiva, dorsal tongue, hard palate. Those are the three places. And are all three of those places the same thickness of keratin? No. So knowing what should be present tells us if we have hyperkeratosis. So it always has to be more than is normal for the site. So all of the places in the mouth that have movable mucosa, except for dorsal tongue, are non-keratinized. And even a little bit of keratin at those places would be considered abnormal and would be considered hyperkeratosis. Hyperkeratosis by itself can be totally innocuous. Have you studied anything so far that has hyperkeratosis that's totally innocuous? Do you know what innocuous means?
No.
Totally harmless. Innocuous means harmless. So what have you studied so far that has hyperkeratosis on the surface that's totally harmless? Fibroma is from under the surface, but can have hyperkeratosis also. That's not a diagnostic feature of a fibroma.
Linea alba.
Linea alba should have normal keratin. It's just a change in configuration. But you're close. Granulomas, no. Morsicaceobacarum, defined by excess keratin on the surface. And it's totally harmless, but that is a pathologic finding. Another type of pathologic change that we can have that's in the epithelium is dysplasia. And you have learned about dysplasia with your discussion of neoplasia. So what are important features of dysplasia?
Irregularities in cell size.
Altered architecture, failure to mature as the cells migrate to the surface, larger cells, larger nuclei, hyperchromatic nuclei, those kinds of things, but it's all contained within the epithelial layer. What was another really important thing that you learned about dysplasia? It is not the same as in situ carcinoma. It can get very severe, but not severe enough to be called in situ. Once we get to that level of severity, it's no longer dysplasia. It's in situ carcinoma. So those is crossed a line. What else have you learned? When it involves epithelium, it's always considered to be premalignant. It could progress to malignancy. And if it progresses, it might go through the pathway of that carcinoma in situ before it becomes invasive carcinoma. And sometimes it goes directly to invasive carcinoma without the histologic features of what we call in situ carcinoma. So just from those first two pathologic changes, you should be aware that within this category of epithelial lesions, we have things that can be totally innocuous. We have things that could be on the spectrum of becoming cancer over time. We can have proliferative changes where we have more epithelial cells present, and sometimes that's an adaptation like a hyperplasia. And sometimes that's because we are in the process of becoming a neoplasm. Those can be benign neoplasms, those can be malignant neoplasms. And of course, the last thing would be invasion. We can have epithelium that's growing into the deeper supporting connective tissue, and that would always be a sign of what? Malignancy. And because epithelium is of epidermal origin, it would be a carcinoma and not a sarcoma. So yeah, that's kind of the spectrum of pathologic changes that we're going to see in the specific diseases that we call epithelial lesions. When we think of clinical appearances for the group, we have some special terminology that we use for certain categories of clinical presentations, and we'll be talking more about those, maybe even get to them this morning, might get to them Friday. White patches. So sometimes our epithelial lesions present clinically as a white patch or a white plaque, where we just see a little minimal bit of thickening on the surface, but it's distinctly white. Those white patch lesions have a component of hyperkeratosis. Keratin makes them very white in the mouth, and it's a paper white. There are different shades of white. It's a paper white, very white. We use the term leukoplakia when we have a white patch in the oral mucosa that doesn't wipe off or scrape off. It's not scrapable, and it cannot be characterized as any specific disease based on its clinical presentation. That's a very important part of the definition of leukoplakia. We'll come back to that again, but it just refers to a clinical appearance because it's easier to say one word leukoplakia than that whole long description when you're trying to talk to somebody. Sometimes the white patch has some areas of red mixed in with it, and then we call it speckled leukoplakia. Sometimes we see epithelial lesions that present just as a red patch, cannot be clinically characterized as any other specific disease on the basis of its clinical presentation. Have we seen lesions so far that are red or have a red component? Yes, and some of them are very distinctive in their appearance, and on the basis of their clinical presentation, appearance, and history, we have a very strong suspicion that they're a specific disease. We wouldn't use the term erythroplakia for those lesions. We would use the specific disease that they appear to be. So that concept of it not being characterized as any specific disease is really important. Sometimes our epithelial lesions present as a papule. You remember what a papule is? An elevated lesion, fairly small, often with tapering, sloping sides. And then sometimes we just have an outright exophytic mass, a mass that's growing above the surface. And those are the ones where we always have to have a distinct suspicion, is this already malignancy? Is this a carcinoma arising from the oral mucosa? So those are kind of the spectrum of things that we're going to see. And we're going to start our discussion with specific diseases that are really common in the mouth and that you will see. We're going to start with a group of things that are caused by human papillomavirus infection. The one that we see most commonly in the mouth is the squamous papilloma. Squamous is in the name because it is a proliferative disorder of stratified squamous epithelium. So the name tells us a lot. And papilloma is in the name because that proliferative change produces finger-like projections on the surface. That's what papillary means. There are finger-like projections on the surface. But it's a pretty common disorder. I don't care if you know that we see it in 1 out of every 250 adults because that may not be very accurate. It's a common enough lesion that we don't really track it. And so the epidemiologic studies where we get those statistics are pretty old, and who knows if they're 100% accurate these days. But it's still a pretty common disorder. There are many, many, many different strains of human papillomavirus. Do you know how many? At least 100. At least 100 different strains. And more than one strain of HPV can produce clinical lesions that look like squamous papilloma, both clinically and histologically. When studies are done that actually specify the stain by special staining with or in situ hybridization to find the DNA that matches the strain of HPV, We find that HPV-6 and HPV-11 are the most common strains that produce squamous papilloma. I think you should know that 6 and 11 are the strains of HPV that most commonly produce squamous papilloma. But in the back of your mind, you should have an awareness that there are some more. That accounts for 50%. There are others that are less common that account for the other 50%. Because this is caused by a virus, you could get it at any site in the mouth. You could get it at any age. So age, gender, site is not helpful for the diagnosis. What is helpful is its clinical presentation. And this is a lesion that presents as a painless, well-defined, usually round to oval, exophytic, cauliflower-like mass that's pink to white. What would make it more white? And what would make it more pink? How much keratin is present? So when we get these arising at sites that normally have quite a bit of keratin, they tend to be more white. If they arise at sites that usually have less keratin, they can be a little more pink. But the virus itself does stimulate excess production of keratin, so they tend to, even when they're pink, be a distinctly paler pink than the normal tissue in the area. Because this is caused by a virus, there is not a medication that gets rid of the virus. Your immune system can eliminate these sometimes, but if you have studied HPV and microbiology, you are probably already aware that HPV is famous for evading the immune system. It goes into hiding so it can't be detected, and infected cells are often not being recognized as being infected. So the treatment of choice is excisional biopsy. We remove them surgically with a border of normal tissue. We try not to touch them during excision because touching and manipulating the lesion itself can spread the virus. There are also studies that show that even the normal tissue immediately around them is infected. So we have to take a border of normal tissue to get rid of them. A lot of people don't know that, and they excise too conservatively, and then these recur because they didn't get all the infected tissue out. So what do they look like? So I have a couple of examples. This one's really old. The patient is rolling her own lip down, and you can see the 1970s fingernail polish color. But nice mushroom or cauliflower-shaped little white mass with that delicate, small little capillary surface. Another one at the junction with a soft palate, well-defined, exophytic, and you can see the little pointy projections. That's what we call papillary. So when we see this presentation in the mouth, the most common thing it's going to be is a squamous papilloma. They tend to enlarge very, very slowly. This is a squamous papilloma on attached gingiva. It's a little different because it's broader and more irregular in shape. But can you see the papillary changes on the surface still? So you should have a suspicion. Why do you think this one might be bigger and irregular? Smoking doesn't have any impact on it. They touched it with their tongue. That won't spread it. But over manipulating with floss or a toothbrush, so you get in and cause some bleeding, can spread it. So we do recommend that they be removed so they don't spread, but they're pretty innocuous. And regular squamous papillomas do not progress to cancer. When we look at them histologically, we do see thickening of the epithelium. We see those proliferative changes with a little bumpy surface and extra keratin. And then we see kind of a branching, supporting core of connective tissue. If we look really closely, we usually see some lymphocytes in the connective tissue. So the immune system is hunting, but often doesn't find the virus. And we see little evidence of viral infection under regular H&E histologic examination. The other common HPV lesion that we see in the mouth is verruca vulgaris. Verruca vulgaris is the Latin term for common wart, ordinary common wart caused by human papilloma virus infection. And there are multiple strains that cause the common wart. HPV 2, 4, 6, and 40 are the most common ones, but these are very, very frequently also on the hands. They are also a little more common in younger people because especially kids that touch everything, they put their hands in their mouth, they touch things, and then put those things in their mouth and they touch each other. So they spread a little more easily. And the strains of HPV that cause the common wart do spread a little more easily than the strains that typically cause our squamous papilloma. But we still can see it at any site in the mouth and any age patient, but we do tend to see them a little bit more commonly than in younger people. How do they look clinically compared to squamous papilloma? Well, pretty much the same. We have some very arbitrary rules that we apply to distinguish them, but really the best way to distinguish them is do HPV typing. If a patient has warts on their hands and oral lesions, we always call them verruca vulgaris because we don't normally see squamous papilloma on the skin. It's a mucosal lesion. If we do histology on them and we see these ballooned epithelial cells with a shrunken nucleus and a clear halo around it, that is evidence of HPV infection, and we tend to see lots of those. We call them coilocytes. So if we see lots of coilocytes, that favors the diagnosis of verruca vulgaris because we don't usually see these with our squamous papilloma. It's a little more obscure. In the mouth, they tend to have papillary projections that are a little longer and pointier than the squamous papilloma. And see, you can see longer, pointier here in the hard palate, longer, pointier here on the posterior buccal mucosa, really right by the pterygomandibular raphe. But sometimes they're low and broad. Those were all common ordinary warts on the vermilion lip. So it's kind of arbitrary what you call them. And for clinical differential diagnosis, you can use either term, but you should be aware in the mouth that we do see squamous papilloma more frequently. So that's often what we put first on our differential just because it's more common. I always call them verruca vulgaris if they look longer and pointier, but it's super arbitrary. Super, super arbitrary. Is he a cute kid? You see his lesion? You think you do? Were you right? He has multiple little papillary lesions on the skin border and vermilion border and mucosal part of his lip, but he also had multiple warts on his skin. So when we have multiple lesions on the skin, we always call them verruca vulgaris. I ask my patients to show me their hands, and I look at their hands to help decide. Another reason I look at their hands is treatment. If you've got them on your fingers and you don't get the skin treated and you treat the mouth, you're going to re-inoculate the mouth with the hand lesions. It's going to come back. So when we have lesions at both sites, we have to have the patient referred to dermatology through their medical system, treat the skin, then we treat the mouth, and that usually works better. Question?
I was going to ask if it was inoculation from hands today.
It very commonly is. And even if you're not a kid, we still put our fingers in our mouths all the time to floss, to pull food out from between our teeth. We do stuff all the time.
If they treat the skin, like, if they're gonna get again inoculation like from the mouth to the skin.
Oh, if you treat the skin, can you re-inoculate the skin from the mouth? It's possible, but it doesn't spread that direction as easily. And we don't really know why. And both of them tend to come back and can be a little bit difficult to eradicate because it's the basal cell layer that's infected, and you've got to eradicate all the way down to the basal cell layer. Dermatology likes to freeze them off with liquid nitrogen, often doesn't get deep enough. Sometimes they laser them. There are issues with that, but they don't usually like to go surgery, so getting rid of them can be difficult. So we are leaving our HPV lesions, our common human papillomavirus lesions, and moving to another category of epithelial lesion that we call frictional keratosis. Frictional keratosis basically means you have a callus in your mouth. If you have shoes that don't quite fit and rub your feet, you get a callus. What does that callus look like when your feet are dry? Just thick skin. But if you soak your feet in water, the calluses turn white. And because the mouth is moist all the time, frictional keratosis will present as a white patch. Do we call frictional keratosis leukoplakia? No, because we can characterize it as a specific disease, which is our frictional keratosis. So the key when we see white patches in the mouth is to look for sources of mechanical irritation. Do we already know of any more specific clinical patterns of frictional keratosis? Trauma is a whole category, not a specific diagnosis, a category of cause.
No.
No.
You just made
I'm
that.
not sure what you're saying. Maybe it's my ears, I didn't hear you. Our morsicacio group, from chewing your cheeks, morsicacio buccarum, chewing your lip, morsicacio labiorum, chewing your tongue, morsicacio linguarum. Those are specific patterns of frictional keratosis that get a special name because it's a specific underlying cause, habitual chewing of the tissue. But we can have friction, chronic mechanical irritation of other sources. We can have a dental restoration that's very rough. We can have a broken tooth that's sharp, that's rubbing and irritating. So anytime we see white patches, we have to look for local possible causes and think about habits as well. And if we can identify a source of local mechanical irritation, physical irritation, then that tells us this is frictional keratosis. And we just get rid of the mechanical irritation and the callus will go away. So it's not leukoplakia, it's not premalignant, it's just a local physical injury, basically. And if we can get rid of the source of injury, it'll go away. This is a patient who has a couple little white patches, little tiny ones on the ventral tongue next to a tooth that it has very sharp edges where they prepared the tooth with rest seats for a partial denture, but the patient doesn't wear the partial. And because of that, the irregular surface contours are always catching the tongue and irritating the tongue. So either wear the partial or fill those rest seats with something, and that should get rid of the frictional keratosis. This is a patient who had an old denture that didn't fit, was very rough on the inside, has a little frictional keratosis on the ridges and vestibules. Dentures are usually pretty smooth on the inside. They don't really commonly cause a frictional keratosis, but it is possible. So we always have to check the fit and the internal surface. That's another cause. We have also a common one that we see right on the crest of local focal edentulous ridges. We call that alveolar ridge keratosis, like a person who's missing one tooth, don't have it replaced, and just normal eating will push food against it and you get a little area of white wrinkly surface on the ridge. Question?
Well, most patients that have dentures have
Frictional keratosis?
Yeah.
Most patients who have dentures do not have frictional keratosis. The dentures actually protect the tissue from mechanical irritation. So it's actually very unusual to see frictional keratosis under a denture. Question?
So, if we are, like maybe for the exam, the final exam, if we're looking at this and we're trying to differentiate between Marcasio barcarum and this, what was the biggest?
Can you chew your ridges?
Oh, okay. No.
So this would never be called morsicacio.
Okay.
Yeah, that has to be chewing the tissue with your teeth or your dentures, but not the denture base rubbing on tissue. So this is not from a chewing habit. All right. So those are kind of innocuous sorts of things that we see, the HPV lesions and the ordinary frictional keratosis. Most of the rest of the things that we're going to talk about that are of epithelial origin are things that are related to oral cancer or could become oral cancer over time or look like they're oral cancer occasionally. They're really only loosely linked to oral cancer. So before we move on any further with our epithelial lesions, we have to at least introduce the topic of oral cancer. When we use the term oral cancer, we mean cancer of the oral mucosa, which is everything anterior to the edge of the soft palate uvula. Anything posterior to that is oropharyngeal cancer. Has Dr. Grandi talked anything about oropharyngeal cancer? Yes, what has she said? What do you remember? Caused by HPV. And we're in a good position to screen for it, so we're actually going to talk about that when we get to oral cancers, but it's important to recognize that oropharyngeal cancer is not the same as oral cancer. It's posterior to that anatomic boundary and down the throat. So it includes tonsils, base of tongue, oropharynx, pharyngeal wall, that area. What sometimes becomes confusing with oral cancer is that it does include vermilion lip, because vermilion lip is mucosa and it's an extension of the oral mucosa, but it does not include the skin around the lips. Can we get squamous cell carcinoma on the external skin? Absolutely, absolutely, but we would not call that oral cancer. But if it's on vermilion lip, it's in the category of oral cancer. So that's kind of how we apply those terms. Oral cancers account for 3% of cancers in the US. There are some countries where oral cancer is the #1 cancer, the single most common one, but not in the US. Areas in India, some areas in Southeast Asia, where they have habits that are more carcinogenic than ours, we see more oral cancer. About 4% of cancers in men are oral squamous cell carcinomas, oral cancers, but only 2% women. Women haven't quite caught up, maybe never will. About 30,000 new cases of oral cancer every year in the US, and the overwhelming majority of them are squamous cell carcinomas arising from that surface mucosa. There are other kinds of cancers that we can get in the mouth. Cancers arising from lymphoid tissue. Cancers arising from connective tissues are very uncommon. Cancers arising from salivary tissue, a little more common. And technically, oral cancer also includes cancers arising in the jaw bones. But those are pretty rare, pretty rare. So the majority arise from the oral mucosal epithelium, and they are squamous cell carcinomas. We have concerns about oral squamous cell carcinomas because the survival is not so good. 5-year survival has not changed a whole lot in terms of improvement in the last 50 years. Over the same time span, we've had drastic improvements in survival of other types of cancer, but not so much oral cancer. Overall survival rate depends on the study you read, can be up to an average of about 55% 5-year survival. What does 5-year survival mean? Dr. Grandi teach you that? It is just a statistical number of the percentage of people with that cancer diagnosis who are still alive 5 years later after diagnosis. Regardless of treatment, lack of treatment, good quality treatment, whatever, it doesn't matter. It's just a raw percentage of how many are still alive. But when barely half are still alive 5 years later, this is not a good thing, not a good thing at all. So we have some issues that need to be addressed. One of the biggest reasons that we have the poor survival with oral cancers is they tend to be identified in a late stage. So do you know what a stage for cancer is? You should. What does a stage mean? What's a fast and dirty definition of stage for cancer? It's the extent of disease or tumor burden at the time of diagnosis. And we look at that in terms of the size of the primary tumor and the tumor burden in terms of local metastasis and distant metastasis. So we often find oral cancers when they've already metastasized to local lymph nodes or they're very large. So because they're in the mouth, we think that we as hygienists and dentists are in a really good place to screen for these. And we can play a role in early detection that could improve those statistics, we hope. So one of the reasons we do our oral soft tissue exams is to look for anything that might be something that is either oral cancer already or one of those precursor lesions that could become oral cancer over time. As it turns out, we see far more lesions in the mouth that are not related to oral cancer, but that always has to be kind of high on our list of suspicions. We have to always think about it. When you do your oral soft tissue exams, do you tell your patients that you're also screening for oral cancer? Good, you should. They should know that when you don't find anything, that you've done an oral cancer screening exam and didn't see anything suspicious for oral cancer. Patients like to hear that. It sounds good. All right. So prevention is also another way that we can improve oral cancer survival, and taking a good history with our patients to identify contributing factors for oral cancer and telling our patients that these are things that do promote oral cancer, directing them to places that can help them eliminate those habits. That can be very, very helpful. And hygienists are in a really good position to do good patient education, often are better at that than the dentist. So prevention is something that you can play an important role in. What's the number one thing that contributes to oral cancer in terms of causes? Smoking. We haven't gotten that far yet, but you all know it. So do you take a good smoking history with your patients? You should. Do you tell them it can cause oral cancer? You should. And then when you do your oral cancer screening exam and you don't find anything, you can tell them that they didn't have any suspicious lesions, which means it's a great time to stop smoking while you're ahead. Yeah, this is good. You've gotten away with it so far, good time to quit before it causes any problems. Anyway, oral cancers are known as the great mimickers. And the funny thing about oral cancers is they do not mimic benign neoplasms. They mimic reactive lesions and totally innocuous things, and sometimes even infections. And so we kind of have a rule because of that. Look carefully, suspect everything. Never dismiss something as, oh, that's nothing. Everything is something. Think about what it could be. Think carefully if there's a possibility that it could be oral cancer. So let's talk about those contributing factors. Definitely in the United States, tobacco is the leading contributing factor. It has all kinds of chemicals in it that have carcinogenic properties, produce mutations in our growth and regulatory genes for cells, allowing for uncontrolled growth over time. When you take your tobacco history, it's really important to find out what form of tobacco they're using, how much they're using. How detailed do you go? Do you ask them if they smoke cigarettes or a pipe or cigars, or do you just ask, do you use tobacco? You ask if they use spit tobacco or chewing tobacco. You should always find out what form and how much. For smoked tobacco, we always record it in pack years. So the number of packs a day times the number of years that they've been smoking, that's their pack years. Yeah, the higher the pack year history of tobacco smoking, the greater the risk for oral cancer. So knowing that pack year risk is important. Not all forms of tobacco have the same risk for producing oral cancer. Definitely smoked tobacco has the greatest risk compared to smokeless tobacco. And how you smoke it also makes a difference. There are some places in the world where they put the lighted end of the cigarette in their mouth and inhale. It's called reverse smoking. not popular in the US, but we sometimes see it in fairly recent immigrants from those parts of the world where it's common, including Southeast Asia and India. India, it's very, very common. Reverse smoking has much, much higher risk for oral cancer than inhaling from the non-lighted end. So even finding out how they smoke their cigarettes can be very helpful.
Why would they do that? It's more nicotine?
Nobody knows how, I don't think anybody knows how it got started, but it's a very cultural thing, very cultural. And when other people do it in your culture, you learn to do it that way too. But it's been going on so long, I don't think anybody knows how it got started. I don't know, weird. Second major contributing factor is alcohol. There are a lot of people who drink alcoholic beverages who contest this, but the studies are pretty clear that alcohol independent of tobacco is carcinogenic. It's been hard to get those studies because most people have both alcohol use and tobacco who get oral cancer. It's very common to have both. So getting pure studies that just show alcohol by itself is carcinogenic has been a little bit hard, but we do have those studies. When you smoke tobacco or use other tobacco products and drink alcohol, that actually multiplies your risk. It doesn't add to your risk, it multiplies your risk. So if you're going to have your vices, just have one. It's better than having both. Actinic radiation is also a very important contributing factor for cancer, oral cancer. That means sunlight. If you think about it, this really can only apply to one site for oral cancer. And what would that be? Lips, vermilion border of lips. And it's almost always, like 99.999% lower lip. Why is that? Because it's pointed out right where it catches the rays, whereas vermilion lip on the upper lip tucks under, and the skin of lip actually kind of shades it. So actinic radiation is the #1 factor that produces lip cancer, #1, but is not a factor in any way for intraoral cancer, because even if you're a mouth breather and sleep on the beach with your mouth open every day, you'd have a hard time getting enough sun exposure to get actinic radiation-induced intraoral cancer. Betel quid is an important contributing factor in some cultures. Betel quid has betel leaf, areca nut, usually some tobacco, slaked lime, roll it all up, put it in your mouth and kind of suck on it and bite on it, and it releases all kinds of carcinogens from the tobacco as well as from the areca nut. Betel quid use is more common than most people know in the United States, but it comes from people who have immigrated from other cultures. So you can ask your patients about betel quid if you want, but it is more common, again, in that group that does the reverse smoking from India and Southeast Asia, particularly. Sanguinaria, have any of you heard of sanguinaria? It is a plant, and they make an extract from the root, and the extract is blood red. The plant is red, and that's where the name comes from. Sanguinaria plant is red. And sanguinaria has antibacterial properties, and so the extract has been put in toothpaste and mouthwash. It's pretty hard to find these days because it was found to produce premalignant and malignant lesions in the maxillary vestibules, a place where we hardly ever see oral cancer from any other cause. So asking your patient what kind of toothpaste and mouthwash they use and screening for sanguinaria use can be useful. But again, not a lot of people use that one anymore. The word is kind of out on it. Some microbial infections contribute to oral cancer. Patients who have tertiary syphilis and chronic candidiasis have higher risks. That's not really well understood, precisely why that increases the risk, but it does. Do we see a lot of tertiary syphilis? No. Probably because we overuse antibiotics for everything. So that's kind of one of the good things about overuse of antibiotics. We don't see so much syphilis. There are some nutritional deficiencies that also increase the risk for oral cancer. The one that you should know about is Plummer-Vinson syndrome, which is a collection of iron deficiency anemia, pain or discomfort with swallowing because of anatomic changes in the esophagus, and increased risk for oral cancer, and cancer throughout the GI tract, especially the esophagus and oral cavity. So the nutritional deficiency is iron deficiency that leads to the anemia. But that's one you should probably know about. So when we are screening our patients clinically for oral cancers, what are the things that are clinically suspicious for an oral cancer? Anything that's white, anything that's red, anything that has a mass, and anything that doesn't have any reason to be there and persists and hasn't gone away. That includes an awful lot of things, doesn't it? So we have to think about, could this be a cancer? With Dr. Grandi's topics in oral path so far, and the one topic you've done with me already, have you practiced doing a differential diagnosis? Your list of possibilities? There are some people that put oral cancer on every differential, just in case, to cover their tush. I strongly recommend that you do not do that. I strongly recommend that you think about the features of whatever you're looking at and whether or not it actually shows any signs that are truly suspicious for oral cancer, and only put oral cancer or squamous cell carcinoma on your differential if there are specific signs that make it likely that this could be, but don't just automatically put it on your differential. One of the reasons I recommend you don't do that is that once you put that on your differential, you're legally obligated to follow up with care for the patient as if this is an oral cancer. And unless you're willing to do that diligence of follow-up, you are buying more trouble. So if you think it is suspicious, by all means, put that on your list, but don't just automatically do that. All right, so what are the clinical presentations that we can have for oral cancers and precancers? The plakias. Our leukoplakias, our erythroplakias, and our speckled leukoplakias. Most oral cancers start with a white patch, sometimes with a red patch. That doesn't wipe off, doesn't scrape off, is persistent, and can't be explained by any other specific disease, doesn't have characteristics of specific diseases. Usually, the leukoplakias and the erythroplakias also don't have symptoms like the other lesions. So what kind of symptoms do most of the red lesions that you've studied so far have? They usually have pain or some type of irritation, because most of the red lesions we see in the mouth are red because of inflammation. And inflammatory things usually have discomfort. So a lot of the lesions that we see in the mouth that really are pre-malignant or already malignant are painless. And they're usually solitary. If you notice, the red things that are from irritation or infection or skin diseases often are multiple. A lot of the things that produce red changes, it's multiple areas. A lot of times, the pre-malignant things are just one lesion, just one area, just one. We have this concept of field cancerization because the whole oral cavity has been bathed in carcinogens. You can have more than one area that's pre-malignant or becoming malignant. A person who has one oral cancer has a greater risk of getting a second oral cancer than a person who's never had any oral cancer. So it could be more than one lesion, but often it's just a solitary painless lesion that doesn't look like any of the other red things or any of the other white things. So those leukoplakias, white patches that don't scrape off, can't be characterized as any specific disease, and the red patches. Those are the things that we watch for that have a really high risk. Speckled leukoplakias are the mixed red and white. We've done studies on biopsy specimens taken from these clinical patterns of lesions. And we know that the erythroplakias have the greatest risk of being cancer or precancer when they're initially biopsied. The speckled leukoplakias are second in risk, and the leukoplakias are the lowest. Just the white all by itself has the lowest risk of being cancer or precancer. So what do we mean by those leukoplakias? White lesions that don't have any reason to be there are persistent and don't scrape off. So do we usually bite the floor of our mouth or have chronic physical irritation in the floor of the mouth? No. We don't have any reason for that little white patch to be there. So leukoplakias usually look like just something white stuck to the surface. Often look like something just stuck to the surface. But it's persistent and it doesn't scrape off and doesn't have a good reason to be there. If this did have maybe, let's see, maybe the patient wears a sleep appliance, like a night guard or something that rubs that, then would it be a leukoplakia? No, it would be a frictional keratosis. So we have to look for local causes too. When we do biopsy studies on things that are clinically characterized as leukoplakias, 80% of them are just hyperkeratosis, excess keratin, with no atypical changes in the epithelium itself. About 12% of them are dysplasias, meaning there are atypical changes in the supporting epithelium, but not enough to be carcinoma in situ and certainly not invasive. About 3% are carcinoma in situ and 5% are invasive squamous cell carcinomas, and usually just microscopic invasion, we wouldn't call it leukoplakia if it has a mass effect clinically. If it looks like a mass with bulk and size, we don't use the term leukoplakia. But even so, 5% of them already have squamous cell carcinoma. Knowing those biopsy study results helps us build differentials for white patches that can't be clinically characterized as anything else. Single most likely diagnosis is going to be just our hyperkeratosis, because that's what the biopsy studies say happen most commonly. Does that make sense? But we know in the back of our mind it could be something more significant. How do we find out what it is? It has to be biopsied. Absolutely has to be biopsied. We're out of time, so I'll let you go to clinic, and we will pick up here on Friday.